Dr. Doyle, ma'am, is an assistant professor in Parul Institute of Physiotherapy with specialization in neurological and pediatric physiotherapy and is currently pursuing her PhD. With over 8 years of teaching and clinical experience, she has developed strong expertise in neurorehabilitation and pediatric care. She serves as the Vadodara District Subcoordinator of the Indian Association of Physiotherapists Women's Cell. She has presented and published research papers at both international and national journals and levels. Actively engaged in academics, clinical practice, and research, she is committed to advancing evidence based physiotherapy and improving patient outcome. With extensive experience and valuable contribution to this field, we are confident that this panel discussion will offer diverse perspective, practical insights, and enriching takeaways for all of us. Over to you, ma'am.
Thank you, Aisha, for the introduction and for the inauguration for this. Good afternoon, everyone. As I warmly welcome you all to this panel discussion by IAPWC Women's Cell, Gujarat State. As today's discussion, we are focusing on a very relevant and evolving concept, that is leaving labs in physiotherapy, integrating research directly into the clinical practice. As this is a very good topic which needs to be discussed further. So we have an esteemed panel today with us. So I'll start with the Loknathan sir. We welcome you all of you and thank you so much to have you here and for your valuable time that you are spending for us. So Loknathan sir is a highly expert and experienced senior occupational therapist and rehabilitation administrator at Jaya Rehabilitation Center, Bidra. Even I know sir very good. When we were studying that time also, sir has good commands on the patient and all the things that you were doing. So we are very happy to have you here, sir. Thank you so much. The next panelist is our Janvi ma'am. Janvi Shah is a dedicated pediatric physiotherapist and child development specialist based in Vadodara, Gujarat, with over more than of 13 years of experience. She is a founder of Braj Child Development Center, a multidisciplinary
Ma'am, you are muted, ma'am.
sorry. Okay. So I welcome our esteemed guest. The first one is Loknathan sir. As Loknathan sir is highly experienced senior occupational therapist and a founder of Jaya Rehabilitation Center, Kutch Bidra. Sir is holding Master of Occupational Therapy and sir is having a more than 26 year of experience, specializing in patient-centered rehabilitation and functional recoveries. Even we had studied a lot many things from sir. So we'll welcome you, sir, in this. And thank you to sparing your time here. Thank you so much. The next panelist we have Janvi ma'am. Janvi ma'am is an dedicated pediatric physiotherapist and child development specialist based in Vadodara, Gujarat, over 13 years of experience in pediatric rehabilitation. Ma'am is founder of Braj Rehabilitation Center, Developmental Center, a multidisciplinary facility which is focusing on early intervention and holistic child care. Her expertise lies in sensory integration, reflex integration, and managing developmental delays through evidence based approaches. She is committed to designing individual therapy plans, empowering parents through the guidance and the awareness with a strong vision. She strives to help every child achieve their fullest potential. We welcome you, ma'am. Thank you. Our next panelist is Dr. Dharmang Vyasa. He is an associate professor at Parul Institute of Physiotherapy under Parul University. He holds a master degree in musculoskeletal and sports physiotherapy, currently pursuing his PhD as a research scholar. With over 13 years of academic and clinical experiences, he specializes in musculoskeletal and sports rehabilitation. Sir has been actively involved in teaching, clinical training, research, contributing to the development of physiotherapy education. His academic contributions and ongoing research reflect his commitment to advancing physiotherapy practice and improving patient care outcomes. Welcome, sir. Thank you to have you here. Our next panelist is Dr. Pragya Langden, ma'am. Is a PhD scholar and accomplished physiotherapist with an MPT in adult neurology and psychosomatic disorders. Bringing over 10 years of experience in clinical practice and academics, she serves as an associate professor at Krishna School of Physiotherapy and Rehabilitation and is the Vadodara District IAPWC coordinator. Ma'am has contributed over 10 publications and have received SSIP grants for developing innovative grants and healthcare devices. She has also honored the Outstanding Women Physiotherapist Award at IAPWC National Conference 2024 and New Delhi. Last but not the least, our next panelist is Dr. Neville Deepak sir. He is an experienced physiotherapist with over 20 years of dedicated service, currently working as in sub-district government hospital in Karjan, Vadodara. He is widely recognized for his patient-centered empathetic approach, making his OPD highly sought after, and his work has been acknowledged and experience appreciated at state level in Divya Bhaskar newspaper as well. A specialist in neurological physiotherapy, and sir is serving actively in numerous community health camps. We welcome you, sir. I welcome all the respected dignitaries and all the panelists to have you here and sparing your valuable time here. So I'll begin with the discussion by inviting our all the guests. And if you are all are comfortable, okay, we'll start with the panel discussion. I recommend please keep your video on. Yes. Thank you, everyone. So we'll start with the panel discussion. Uh, Ma'am, please, whenever you want to speak, you can just raise your hand. So they'll give all the admin authorities, and you will be able to mute and unmute. Okay. So my first question is to Pragna, ma'am. As our topic is living labs and physiotherapy and research and clinical practice. So, ma'am, according to you, what are the key barriers to effective collaboration between academia and clinicians, and how can this be practically addressed?
Thank you, Joel ma'am. Uh, Greetings to one and all. Okay, I hope I am clearly audible.
Yes, ma'am, you're audible.
Okay, thank you, ma'am. Okay, so actually, if we see this question, it is very much kind of into the sync with the topic which we have taken. Okay, when we are talking about implementation of the research into clinical practice through the concept of the living labs. So under this, if we see the first and the most foremost barrier, which we are able to kind of note down between a two kind of the things, that is between a clinician, and the second, it is between a kind of the one who is working into academics. Then the major kind of the difference, it lies between two aspects. That is, the first and foremost thing, it would be that priority, and second one, it would be the kind of the expectation. If we look from the perspective of a kind of the individual who is into academics more, then for them, if we see the success, it is often defined based on the publications, based on the grants, or based on the theoretical type of the contributions what we are kind of giving. But on the other side, if we talk about the clinicians, then under the clinicians, they need to work into a fast paced type of the environments, okay, where they need to kind of do with the priority, the top post, it would be to give the patient care, that is the immediate type of the patient care. And the care which we are giving, it should be also be given into kind of the manner which is to the kind of the level, okay, that is into the most efficient manner and with a good amount of the outcomes. So here, if we note down, that is, if these two things they are being kind of taken, then there is a disconnect which is noted down between the two. And this disconnect, it often leads to a scenario where the research, it is being produced but it is not being used. The second aspect, if we note down, that is the barrier which is being created, it is time. Okay, so if we look from the perspective of a clinician, okay, they need to work into a kind of the thing where so many patients are there. They need to kind of look to the different type of the operational things. They need to look at the administrative aspect. So if we are adding this concept also to them, okay, then it might be little bit kind of a burden thing. It may be looked from their perspective. Okay, if you are adding the research, okay. The third thing, if we kind of look, that there might be a communication and a gap which is from the mindset type of the perspective. That is, if we see someone who is from the academician kind of the part or from the research perspective, they generally use the language which is more technical. And if we look from the clinician kind of the part, then they use the language which is more practical, okay, and with a good amount of the reasoning, and which has a clinical touch from their side. So due to this, the difference which is being created from the language as well as from the mindset point of view, this will also make the collaboration little bit difficult. The one more thing which we need to kind of look, that some of the clinician, they might be kind of finding uh, uh, into a part that this all skills they might be lacking, okay, related to the research part, due to the insufficient mentoring or the training kind of the aspect. And the last barrier, if we kind of note down, it is related to the structural part, that sometimes they may be struggling with the infrastructure or with the funding and that all support. But if we look to all of these barriers, then the answer to all of this, it lies into our title for today, that is the living labs. Okay, then how these living labs can be kind of utilized? The first and foremost thing, if we see that the researcher should not do it into isolation. Instead of this thing, we can go for a co-creation. Okay, what do you mean by co-creation? The co-creation can be done in such a manner that the clinician should be taken into on board. Can along with this, we should be identifying that what are the clinical problems. Based on the clinical problems, the research questions which can be formed. Okay, based on this, the study design which can be kind of implemented, which will make us to kind of take it into a way where the solutions which is actually practically relevant and it is applicable. The second solution which can be kind of sought from this living lab type of the concept, that is, instead of taking the research as a separate task, it should be incorporated into day to day practice. Then in this, how it can be done, that whenever a patient is approaching, so at that time, generally the type of the clinician, they are generally documenting the clinical outcome measure. So this documented version can be systematically converted into kind of a research methodological perspective. Okay, so due to this thing, there will not be a need to kind of do it as an extra task. It would be incorporated into a day-to-day practice. The third thing which can be kind of being used, it is mentorship type of the models, okay, or a partnership type of the models, where the researcher and the clinicians, both of them, they can work together, and which will convert into a kind of the part that both of them might think that they are the contributor of the knowledge. The next concept or the solution which can be implemented, that is very very kind of the essential, that is the type of the support which is required from the institution, that is from the academic institution as well as for the different type of the organization. That is, whosoever it is implementing this all type of the practices, they should be given protected time, they should be given a type of the infrastructure, and the most important, they should be given a separate type of the recognition. Due to this thing, the individual who is motivated to kind of do it, okay, they would be getting more motivated, and thus it can be implemented into a more better type of the version. The last type of the barrier which can be kind of been solved, it is to kind of go with a type of the collaboration, okay, which is converted into a culture in the sense that is a joint type of the meetings, okay, a case type of the discussion, okay, or a shared learning space, if they are being created. So due to this thing, it very much type of the essential that the two can work in together. So if I conclude in this, that this all concept can be brought into together, where the research and the implementation should not take place into a separate entity, but research and practice, both of them, if they are taking place simultaneously, then we can handle all of these barriers quite well. Thank you, ma'am.
Thank you, ma'am, for setting the context for clarity, and you had given so many points which needs to be done. Thank you so much. My next question to Loknathan sir. So, what are the biggest workflow disruptions you anticipate when implementing a living lab model in rehabilitation setup? As in, dry rehabilitation itself a good setup. So, how do you face or how do you anticipate such things there?
Yes, ma'am. So first of all, it is the problem is time management. So as you know that the proper scheduling, the therapy and research, as Madam said, therapy and research we are doing together, because we are getting a lot of patients and we have to the workflow should be continually monitored. So we have to make proper management of time. That is the first one. Second one is using technology. That is a very big problem. So nowadays the technology is increasing a lot of, and robotics now arrived. So making understanding of the technology first to the therapist and to the patient. So that is a big problem to the this thing. And third one, so how the therapy, this whatever we are doing, so how it is effective to the patients. That to data monitoring, that is a thing. When because of the time management, so most of the therapists they are not finding time to keep watch on data management. So that is a major issue now we are getting. So we have facing more problem. Another thing is a coordination between the multidisciplinary team. So we with the area is a totally multidisciplinary team. We have all augmented therapy, physiotherapy, prosthetic orthopedic for everything. So coordination, and we are developing many new model. So in developing new model also we need more coordination between our team. That is very important. And as you know, our JRF center thing, since many years we are developing new thing. And recently we have developed the multi outdoor training unit. So this is a unit, specific unit. We developed specifically for the patients. Once we are seeing the patient's problem on using the public utilities, so we had a meeting, and when assessment, we came to know that patients are facing this kind of problems. So then we assessed, then we plan to make a new model for the public utility training center. And we assess the patients' condition on walking on the roadside, because roadside is not like the even roads. So we develop uneven surfaces also to assess the patients walking on the uneven surfaces. And we developed a road speed breakers also, because these are the many problem challenges we are getting. So this thing we assessed and we are implemented in our rehabilitation center. So every time we are putting a new thing to our center. You have seen our functional training unit. So we developed a small kitchen facility also for the patients, because when going to the home, the patients are facing a lot of problem in their home environment. So that also we developed here. We have developed a different kind of washroom, the toilets, because the patients when going home they're not able to use their regular toilets. So we have made a model how to they can change their home environment to this thing. So we have been to many patients' home, and then we assess the patient's problems. Then we came to know this thing. So now is the important thing coming is robotic rehabilitation. So robotic rehabilitation, it is totally different one. So it is totally digitalized technology. So we are planning for robotic rehabilitation also. But in robotic rehabilitation, we need more therapists to coordinate with the patients. Then only we can maintain our patients flow workflow, so we can monitor our workflow. And then the thing is funding, as madam also told. Funding is important. As our India, there are the poverty is more. So when you are using the technology, so as to the therapist has to spend more money on the technology. So he has to earn that time. So he cannot charge more to the power. So that is the main problem. Funding is the main problem. So that also we are facing to make the workflow more even in our center. So these are many various factors we are facing in our rehabilitation center.
Yes, sir, correctly said. Those are the things. Thank you for highlighting so important practical concerns that is actually mattering the most. Okay, my next question to Dr. Dharmang sir. So, how do you modify treatment protocol when you are emerging clinical data, as specifically that contradicts established guidelines?
Thanks for the question, Dr. John. Basically, when emerging clinical data contradicts established guidelines, treatment modification should follow an evidence hierarchy combined with clinical reasoning rather than immediate protocol replacement. So we should not change the protocol immediately. We should go into the evidence hierarchy and decide that whether the protocol that is being given is sufficient or we need to make some modifications. And this can be done in a stepwise approach where we evaluate the strength of new evidence. That is, we can look into some case studies, especially the randomized clinical trials versus observational methods, sample size and power. What is the power of the study, population similarity of your patients, remove the risk bias, and guidelines are then based on systemic reviews and consciousness of the single. Rather than deciding your protocol based on one single study, we can go into the detail of other studies and then decide that whether we can implement this protocol or not. Second is we can apply evidence-based practice. Evidence-based practice says that basically whenever we go into the research, we should try to find the best available research. Then you add on your clinical expertise to it. Okay, and you do what are the patient's preferences when you are designing the protocol. So different patients may have different preferences of the treatment or of the outcome with physiotherapy. So you should basically work on patient's values rather than working purely on the evidences and designing the or redesigning the protocol. Then you can introduce controlled clinical modifications instead of directly changing the protocol or replacing the protocol. So newly approaches can be used. Using of trial implementations can be done, monitoring the outcomes prospectively. For example, rather than only deciding that the patient feels improvement, we can have some standard outcomes which says that the pre and post VAS for pain was this much. Okay, the functional scales, we can take some which we can say that pre and post, what is the outcome or what is the improvement in the patients, right? So guidelines from different kind of practice and guidelines from different kind of researches should come together, and then a protocol should be designed rather than just jumping onto a new protocol when your current protocol does not give any improvement.
Yes, very well said. That is correct. So that's a actual critical aspect of evidence-based practice. Okay, my next question to Neville sir. So what are the key opportunities and barriers to implementing living labs within a government healthcare setups?
Yeah, thank you for this question. Am I audible? Yes.
Yes, sir, you're audible.
Hello. Yeah, thank you. Yeah, that's what I talking about this government setup. It provides definitely excellent opportunities, such as high patient load. We have so many patients. For example, in my department, I treat around 35 to 45 patients a day. So it's quite high patient load. No, then there is diverse clinical exposure and real world environments that are ideal for scalable and impactful research. So it is really, but the thing is, talking about key barriers, it includes like limited infrastructure. Where I work now, what modalities and what infrastructure I was doing 10 years back, I'm working still with the same infrastructure and all. Even if you want some new modality or something, we have to convince officials at quite more than few levels. No, so it is really sometimes frustrating. Then there are lack of trained assistants. In my case, I have no assistants. I'm single-handedly working in this department, so it is really difficult. And so due to this clinical workload, heavy clinical workload, then there will be funding constraints, right? It is difficult to get a grant or something from government. It is really arduous task. Then there will be bureaucratic delays. We have to convey at every level, from this local level to even state level officials. So it is really difficult. Yeah, and then there is gaps in data analysis systems. So these things are barriers, key barriers, I would say. Thank you.
Yes, sir, thank you. Thank you for bringing this system level perspective as we were not even aware of many of the things. So my next question to Janvi ma'am, how can this living lab model be effectively adapted to pediatric physiotherapy settings where play and engagement are central to the therapy?
Hello, am I audible?
Yes, ma'am, you're audible.
Okay, thank you very much. For a pediatric physiotherapy setup, our main approach is it's a team approach actually. In pediatric setting, actually, it's a team between multidisciplinary therapist in terms of speech therapist and behavioral therapist and the other medical professions, and inclusion of obviously parents and their maybe teachers and the caregivers. So in pediatric aspect, it's a team approach. So to manage and to get a communication loop present within the team is very much important. So for that, clear identification and clear communication should be there. And for that, nowadays there are many technologies present. Some we can take videos of the patient, and the communication is now very much easy for us, for each and every team member to give their inputs. So current scenario, accepting the new technologies and implementing those for the children generalized growth is very much important. So we use play therapy or games and puzzles for as a tool of therapy, and with that also, the communication between the team members is the key role, and that is the main uh, what you say main aspect of our pediatric rehab. And for that, if you see the living labs on recent advances, uh, is helping us to making our therapist more engaging, more participation fetching. So we always welcome all kind of new researches which is there, which is help us to be more creative and engaging for children aspects.
Yes. Thank you, ma'am, for giving this perspective too. So we'll move forward with the more things of practical implication, how it is going to be work. So my first question to Loknathan sir regarding this. So how do you effectively manage time constraints when balancing therapy, documentation, and research activities?
Yes, ma'am. So actually, we just allotting time. Actually, we have 8 hours all day working hours. So just we are dividing this into 45 minutes session for the therapy session for each patient, and it divided into afternoon morning session. So the therapist will get 15 minutes in the afternoon and 15 minutes in the morning. So this is the extra time the therapist is getting. So we allotted this time for the therapist to use on documentation and to using on the researches. Either he can use in between and the session, or he can use on the last of the end of the day. He can use these minutes for the using the documentation and the research. Because under some most of the research usually they are doing on the go therapy only, but in specific, some assessment, many scales or outcome measures, even specifically they want to use that they will do during this 15 minutes in the afternoon or 15 minutes in the evening time. So totally 30 minutes he is getting they're getting in the whole day. So they can use this thing for documentation because our center's document is very important. So we're keeping records for many years. So the document is very important, and daily notes they have to use, and daily whatever the every for neuro patients weekly ones they have make the progress notes, and the research data also they have maintained on their system. So we have a lot of the system in each room, so they are monitoring with the system and they are keeping record on the system and they are tracking on the system only. So this way we are doing documentation, research, everything, and we are promoting all therapists to give new research and go on to you present your research on the thing and then get idea about the new research ongoing. That also you going to come and implement in our center. So we are promoting the therapist also in our centers. Thank you.
Yes, that's good, sir. Okay. Next question to Dharmang sir. How do you manage situations where your clinical experience and expertise conflicts with emerging clinical research data? It happens many a times. So how do you deal with that?
Yes, thank you, ma'am, for the question. Basically, clinical experience and emerging research data in clinics have always been a conflict. Like the people who are into core clinical practice, they do not use any evidence-based protocols for their intervention, which are research-based. They'll use the evidence from their clinical experience or from previous patients' data or whatever they have learned through their clinical training or clinical experience, rather than using standard research data, which we do in regular basis. So these conflicts have always been there, and to remove these conflicts, basically, I think that we have to use a structured clinical audit and bias control. So what we do is first we should recognize the sources of conflict. Clinical experiences may be influenced by a lot of things like clinical bias or confirmation bias, recall bias, small sample exposures, selective success memory, patient's heterogeneity, right? And whereas in clinical research, we may have small sample size data, we may lack some external validity of the research, we may lack to reflect the real world complexity that the clinician faces when we are doing a research. But resolution strategy should always include converting experience into measurable variables. Example, like I said, patients do better is not a measurable variable. Rather than that, we can have return to sports time, we can have limb symmetry index, we can have pain scores, we can have re-injury rates. So these are some of the standard data which we can collect in the clinics as well as during the research to correlate the clinical experiences and the clinical research data. Another, what we can do is we can perform internal clinical audit. What do I mean by clinical internal audit is we have to compare old methods with recent methods. So old methods, like for example, you say that previously it was like we giving ultrasound, giving some stretching, giving some strengthening for tennis elbow was a standard protocol. Even nowadays, a lot of places we see this protocol, but recent evidence says that you have to release some work on the kinetic chain, work on the shoulder strengthening exercises, work on some mobility of the shoulder and elbow, core strengthening exercises, which will further prevent the recurrence of tennis elbow. So this is a new method. So we have to compare the old methods with the new methods and see that what are the changes that have occurred in recent protocols compared to the old protocols with the same inclusion criteria. Third, what we can do is a subgroup analysis. By subgroup analysis, we mean that often both are correct for different patients. Say, for example, same treatment, that is the old method and the new method, both works for different kind of patients. Example, early loading works in athletes. Conservative loading after a knee injury or a meniscal injury works better in sedentary patients. Then we can use some clinical reasoning, like clinical experience should be equal to prior probability of the outcome of your treatment. New research data which are likely giving you more likelihood of outcome, better outcome, and final decision that is based on your clinical expertise as well as the recent research data. Combining both of this will help us to solve the problem. So ultimately what we need to do is we again need to have a structured clinical audit and bias control to remove this clinical conflicts between the clinical experience and the emerging research data.
Good, sir. That is a good suggestion, needs to be done. Okay. My next question to Naval, sir. What opportunities and challenges have you personally experienced while conducting research in a government clinical setup?
Okay, thank you. From my experience, this government clinical setups definitely offer valuable opportunities. Like we have direct access to varied patient populations, and we are able to conduct practical and outcome oriented research that directly benefits public health. Right? So it is one of the most important factor in this area. And at the same time, when talking about challenges, it includes balancing clinical and research responsibilities. While we are treating patients, at the same time, if you want to uh, collect data, it is really difficult, and it is for me it is like highly impossible because data has to be precise and accurate and honest, right? So it is really difficult to balance this clinical and research responsibility. We do need some assistance in that area. Then there will be delays in approval, so it needs to quicken. Then we have limited standardized resources and difficulty in patient follow-up. And once patient gets feels better, no, they go and sometimes forever. We don't see them again. So we don't get the feedback we want for that. So these things are really important, and we need to see to right implement these things. Thank you.
Thank you, sir. Next question to Janvi ma'am. Ma'am, can you share a clinical scenario where real-time data significantly influenced or altered your treatment plan, specifically in your pediatric practice?
Yes, ma'am. Uh, Now real-time data, I bifurcate in three ways. First thing is in technology. As Loknathan sir also mentioned regarding robotics and audiovisual aids, in terms of pediatric thing, There are many multiple apps and games which is really engaging, and we are using that to to become the session more powerful and more effective for children and more engaging. Then the other thing is recent development of or recent approaches to deal with the children are really changing. In terms of before 10 years, we if a child with cerebral palsy or motor or physical developmental delay comes, we see is like developmental delay in motor and gross motor and fine motor functions, but we don't see the child in terms of a holistic perspective, not even the sensory perspective. But now the integration, because of real time integration and research coming out, we see children with a very good sensory motor approach. So with that, the quality of life is also getting improved. The other aspect, the therapy planning is very precise. And the other thing is interdisciplinary collaborations or interdisciplinary as a team approach. If we need to work, there are many kind of uh, applications and AI tools are nowadays available. So communication within the team is uh, very much effective way of communication is happening. The other time is the documentation aspect is taking less time. So in our center, we do a quick assessment and documentation every 15 days and every month. But with the help of applications and our own chatbot, AI chatbot, it is very easy to document all the aspect, and decision making and goal setting is now getting very easy and less time taking. So, and due to that, we can discuss the case with the other team members, and effectively and precisely we can implement therapies. Thank you.
Next question to Pragna ma'am. Do you foresee academic and clinical collaboration becoming a mandatory component in physiotherapy education and practice in the future?
Okay, thank you, ma'am. So if you see, it's a very forward-looking question. Okay, and if you look to the kind of the part that if you look to the question and the answer to it, it is reflecting to a zone where our kind of physiotherapy profession it is now moving. I wouldn't say that the kind of the collaboration between the academic and the clinical, it would become very much kind of a mandatory into a strict manner, but I think it would convert into a zone where it would be very much kind of deeply embedded, or it would be essential from the perspective of the education and the practice. One of the main reason for this, it would be that now if you see the physiotherapy, it is kind of completely dependent on the part that is, if we give any amount of the solution of the treatment, it is completely based on the evidence. Okay, that is the evidence based practice. And because of this, the physiotherapy, it is now no longer kind of considered where we are only giving the treatment which was being kind of established from a good amount of the time. But instead of this part, we are continuously kind of checking, that is, we are kind of just taking all the treatments, we are trying to analyze them, and then we are kind of putting them into a zone where it is converted into an evidence kind of the part. But in this also we need to acknowledge that there is a challenge, okay, because the research which is being conducted, it is being done into a very controlled type of the setup, okay, and it is not taking into consideration the different type of the complexity which can be kind of noted down. And at this point, the collaboration, it is very much kind of critical, that is the clinician can bring the real life type of the insights, and the academics kind of the part, they can bring the methodological rigor. Can if both of them, they are being brought into a sync, then the evidence which is being kind of generated, it would be very much scientific, and it would be clinically very much relevant, okay, by which it can be kind of applied to a good amount of the patients. Another important factor, if we see, there is a gap. The gap, it is noted down between research and practice. That is, it may takes a good amount of the years. Okay, sometimes it may takes even decades for the research findings to be implemented in routine care. And this type of the delay, if we are kind of seeing, it will lead to the impact on the type of the research which is implemented to the patient outcomes. But to this also we have solution, and the solution is living lab only. Okay, that living lab, it will lead to the integration of the research directly into the clinical type of the environment. So instead of we are waiting for the evidence, instead of this thing, we can translate it, it can be generated, and it can be applied at the simultaneous time. In term of one of the thing, if we note down, that is from the perspective of the education. Now the students, okay, in that also we are able to kind of see a shift. Okay, that is physiotherapy students, they are kind of, now they are taking an active participation into different type of the research projects. Again, they are also identifying that research, it is not something extra, but research, it is a natural kind of the part which will help them for the clinical reasoning, and ultimately kind of lead to a decision making capacity for the betterment of the patients. So looking ahead, if we see, there should be a kind of the model which is a combination of both. Okay, and if this both of them, they are being kind of getting converted, that is a clinician researcher part. So in that, a better patient care, okay, which can be kind of implemented, and this will help us to bridge the gap also. Okay, so to summarize, this collaboration, it will not be mandatory, okay, but it would be essential, okay, to kind of define as a core aspect for a competent physiotherapist. Thank you, ma'am.
Thank you so much, ma'am, for making this concepts more clear. So before we move to the audience interaction, one last important question to Dharmang sir. So how can routine clinical documentation be systematically transformed into high quality publishable research data?
As per my understanding, problem goes is that the clinical therapist, those who see patients every day, and probably the number of patients is quite large compared to a lot of academic institutes, they think that research is not their part to do. So the biggest problem with physiotherapy that I find is that the clinical therapist who is working with the patients or who is directly in contact with the patients considers that research basically is a part of academics, and maybe it is not needed for a clinician to do any kind of research, right? But we need to understand that these clinical therapists, those who are in direct contact with the patients and probably see more than 50 or 60 patients at an average per day in their clinics, can do a research at a much more better levels compared to a lot of academic institutes because of the exposure to the patients. So routine clinical documentation can become publishable research through structured standardizations and outcome tracking. That is, we need to convert notes into structured data. Say, for example, we can have diagnosis, collections, or classifications. We can have intervention categories. We can have time-based progressions, objective outcome measures. Example, rather than, like I said, patient, we can just, rather than only mentioning that patients is improving, what we can do is we can measure the VAS for pain. We can measure the range of motion. We can measure the strength. We can take a lot of functional scoring or functional test scores, where we can collect this as a data rather than only doing it as a documentation that the patient has improved or the gait has improved or the patient has reduced pain. Rather than that, giving them a structured proper outcome measures will help us to create a more publishable data. Second is we can use validated outcome measures. For example, KOOS for knee, WOMAC scale, we know, or work balance scale, we have rate of perceived exertion. Then we have modified Ellsworth scale for spasticity. Right, so we have a lot of internationally valid outcome measure which can be used as outcome tools rather than only interpreting the data in form of improvement in the patients. This can also be collected and used for publishing or for paper publications or for research publications as data. Third is maintaining longitudinal follow-up. Longitudinal follow-up means that the therapist needs to be in constant contact with the patients. What we usually do is once the patient is discharged from the OPD, we shift the patient to home-based program, and then after a month, patient may come for a month or so intermittently for a follow-up, but then after a month, the patient disappears and the therapist is not much keen on keeping contacts with the patients wherein they can take a long-term data. So first we need to do a baseline assessment. After my rehabilitation, I need to do a post-treatment assessment, say after 3 weeks or a month, right? After that, we need to take a regular follow-up every month, or say every 15 days, then 1 month, then 1.5 months, 2 months, 3 months, so that we can have a longitudinal data for up to 6 months or a year to understand that how effective the treatment was. What was the rate of recurrence? Third is convert into an observational study where your clinical data can become case series, cohort studies, retrospective analysis, clinical audit studies, right? And in the end, we can have a lot of collection of this data or documentation in the form of standard data, which can be used for publication and can have better outcomes as research. Thank you.
Thank you, sir, for giving this clinical expertise. So I'll open the floor for the audience. Like if you have or if you want any questions to be asked, please raise your hand so we can allow you to speak.
Respected
Yes,
sir.
Aisha.
Yes. So this question is because in the previous discussion, someone mentioned that it is important for a clinical person before opening a clinic for a master student or a recent clinical, someone who want to open a new clinic. It is important that they join some academic institution first and then gain the opportunity of opening a clinic because it would help um, to gain the expertise better. So, what are your thoughts about it?
Okay, fine. So I would like to answer to Aisha saying that Aisha, the basic concept behind saying that a fresher should join an academic institute for a year maybe is to make you understand that how can you do a clinical research. See, in masters, when you do research, you basically have an idea of how research can be done. How do you collect data? How can you form or how can you look for the problem? How can you design your research, right? And how can you do the data collection and all? But what happens is once, say, for example, if it is you, if you finish your masters and if you directly go into the clinics, I don't think that you are going to work anything where you are going to do research. Your main concern is the number of patients visiting your OPD and the earning, probably. That is your first priority. But then research comes in the last. Like no clinical therapist, I have seen very few. If everybody else in the panel agrees to me, very few clinical therapists we have seen who are keen into research and they are doing research, probably 1 or 2 papers in a good journals in a year. But majority, say 80 or 90% of therapists who go into clinical practice, even after doing masters, okay, they forget about doing research, and that is why we have a lot of lack in the evidences when it comes to physiotherapy. And actual evidences which can help a clinician to become a better therapist in terms of treatment approach. So the concern here for saying that at least you need to be into academics for a year is to make you more keen on research. And in that 1 year, you should try to understand that why research is important and how a good research can be done even with minimum number of sample size. You don't need to take always 50 or 60 patients. You can even have a good clinical research with 20 patients, 10 patients, but then you give a better evidences which will help you to have a better clinical practice.
Thank you so much, sir. And thank you to all the panelists.
Any other panelist has to add something for this?
Yes, I would like to add on the things that to become a good clinician, there are many skills yet to develop when you are in terms of in a clinical practice as a fresher. That is not only your personal professional skills, but over and above, you should develop many soft skills. How to communicate professionally with others, how to make a system for your clinic, how to counsel the patient, how to convey your expertise to some other non-professional person. So, in other than Dr. Dharmang rightly said, the evidence-based aspect, you will able to learn all those soft skills in a academic scenario, and that is my personal experience too, that if you go into some academic institute, you will get plenty of opportunity to communicate different kind of people, different kind of patients, and to get a real time scenario of a local situation, as well as in which skill you are good at, you will able to judge yourself, and in which area or in which aspect you need to work further. There were times in 70s, there were times when you have a small illness, you will go to your family physician. But nowadays it is the medical scenario is getting changed lot more. Nowadays super specialization in the medical field has happened. So even you have some of the issues, you won't go, like you have back pain, knee pain kind of issue, uh, patients are aware where to go. But now, as a clinician, I would expect that should be come in our physiotherapy too. When you have certain kind of issue, the environment, we need to develop an environment with our skill, with our cumulative team approach, that there is specialization in physiotherapy, and the physiotherapists are expert in neurological conditions, are trained and skilled to give you precise treatment. So all those things, to get clarity of your thoughts, maybe a academic institution or a well organized clinical scenario will help pressure to give insight more meaningful. Thank you.
Yes, thank you so much, ma'am. So, as we'll conclude today, thank you for all your valuable responses and all the suggestions that you had given. As we conclude today's discussion, so I feel that there are certain highlights that integrating research into clinical practice is not just ideal, but it is achievable, definitely. Challenges are there, it must exist, but with structural approaches, it can be addressed properly. And collaboration between clinician and academia will be the way forward. And it needs to be done for a better patient's treatment and outcomes. So we all need to think on it. We all need to focus on that, and that is much better for the our field as well. I sincerely thank all our respected panelists for sharing your valuable insights and experiences. Thank you to the audience for your active participation, and thank you once again to all the panelists. Thank you so much. Have a great day ahead, and I hope that everyone has gone through a good suggestions and knowledge from you all. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, ma'am.